Hello, my name is Lakshay Jain. I'm a second-year internal medicine resident at the University of Texas Health Science Center at Tyler, the residency program at Christus Good Shepherd Longview. My case presentation is titled Nothing Sweet About It, an Atypical Presentation of Sweet Syndrome. For some background, Sweet Syndrome is a rare and poorly understood dermatologic condition that falls under a group of related disorders known as neutrophilic dermatoses. Three variants or subtypes of Sweet Syndrome exist, and those are drug-induced, malignancy-associated, and classical. Pyoderma gangrenosum is a closely related disease that's also a neutrophilic dermatosis, and both of pyoderma and Sweet Syndrome have very similar presentations, histopathologic patterns, and treatment regimens. My case is regarding a 49-year-old male who has a history of hidradenitis suppurativa, who presented to the ER with a 1-week history of progressively worsening bilateral forearm rash. The rash initially began as 1 to 2 centimeter hypopigmented lesions over his left arm that ultimately progressed down to his left hand and over to his right arm and hand. The lesions were exquisitely tender, erythematous, and inflamed with areas of central necrosis and crusting. The patient was initially started on broad-spectrum antibiotics with the thought he had a severe skin infection, but even after several days had no response. We subsequently obtained a skin biopsy, which showed pseudoepitheliomatous hyperplasia with intense inflammatory neutrophil infiltrates and reactive keratinocytes, and were able to make a diagnosis of Sweet Syndrome, which I will expand on in a moment. The patient was started on oral steroids and had significant improvement within 2 days, and he was ultimately discharged home on a steroid taper. At 1 month, the lesions had completely resolved, and all that remained were well-healed hypopigmented scars. This patient had no history of recent medication changes or evidence of underlying hematologic or organ malignancies that would suggest drug-induced or malignancy-associated Sweet Syndrome. We diagnosed him with Sweet Syndrome based on major and minor criteria that he met nearly all of. The patient failed to meet the diagnostic criteria for pyoderma due to him having no evidence of pathergy or lesions being present at areas of minor trauma, him having no evidence of inflammatory diseases, or lesions being present on the lower extremity. However, despite this, many of his features, including the patient's demographic of being male, while Sweet Syndrome typically has a gender predominance of female in the order of 15 to 1, as well as his lesions appearing ulcerative, as is more common with pyoderma, and with cribriform healing or wrinkled paper-like healing, are much more characteristic of pyoderma. Upon further literature review, it actually turns out that there is little discernible pathophysiologic difference between the two diseases, and many authors even propose that both are actually on a spectrum of a single disease instead of as two distinct entities. We present this case as an example of a patient that may exist somewhere between these two diseases, as he has characteristics that are present in both diseases. Thank you.